Good morning. I'd like to thank Professor Ranjan Mittal to give me an opportunity to interact with people like you who are going to be our future of this country and indeed the world. My topic for today is about leadership and NGO, an interesting journey. So there are three components in this topic. One is leadership, one is the NGO, and the third part is the journey. Now, I am a cardiologist who has practiced globally for the last 30 years and has seen a lot of ups and downs in the innovations of technology in the cardiological field. So I'd like to have this as an interactive lecture if it's possible. So may I ask you, would anybody know what the cost of a heart surgery is in India today? How much? 2 to 5 lakhs. Yeah. That is in the top corporate hospitals. Average is about 2 lakhs. And the cost of the surgery, say about 15 to 20 years ago, how much was it? Any idea? Same heart surgery is actually the double of what it used to be today. So, given the fact that the surgical cost has come down to half what it used to be a decade ago, and the technology has actually trebled or quadrupled in the last 10 years from where we are say maybe in the 1990s and 2000. So that says a lot about what cardiological process has gone through. So if we talk about the Indian landscape, about the health scenario, the Indian government spends about 1% of its GDP on public health care, which is awfully low. And overall expenditure on health is about 5% of the GDP, where the Asian average is actually 6%. And the number of physicians per 1,000 population is 0.5, which is one of the lowest in the world. If we compare to even some developing countries and underdeveloped countries, still their number of physicians per 1,000 populations is close to 2 to 3. So the recommendations for the WHO is about a doctor per 1 doctor per 1,000, and at the moment we are actually 1 doctor per 1,700 patients. So we have about 6 to 6.5 lakh doctors available in India, where we actually require about 4 lakhs more by 2020. And the doctors who are required spread between 50,000 doctors in the primary health centers, about 80,000 doctors in the community health centers, 1.1 lakh doctors for the sub-centers, and another 50,000 doctors for the medical college hospitals. And 4 lakh doctors which we have a gap is very, very difficult actually to bridge. And this is in the whole Indian scenario. So what is the next steps? We needed a change of how we think and how our health system functions. And what could bring the change? Do you think it could be a policy change in the way we are functioning at the moment? Do you think that we require to produce more doctors, have more medical colleges, and have more doctors coming up? But I don't think that that is the way forward, because we have populations increasing at the same time, and we cannot cope up or match with the number of people who are going to come compared to the doctors we are going to produce. Because you have to understand that medical profession is such that just by producing numbers is not enough. You require quality to actually deliver, number one. And number two, more importantly, you require to actually have the motivation to deliver as well. So is it the leadership in implementing new ideas and processes? The previous presentation which you gave was on Arvind High Hospital, and it was all actually about leadership, about a man who actually thought about what could be done. Nobody thought about it. Maybe a lot of people thought about it, but nobody had the guts or the motivation to implement it. And I believe that people like him in the 70s and 80s, when they started off in a very modest manner, and where they are today is actually kudos to the leadership which they have. So I have with me today one of the leaders of the heart care or the cardiac care in the Indian scenario. And who do you think could be a leader? One with a compelling personal history, one who have a distinctive profile of beliefs and impressive accomplishments in the face of odds. So these are the three things which actually define a leader. So Dr. Devi Prasad Shetty is a very well-known cardiac surgeon, and more importantly, one of the most impressive leaders in the medical field I have ever come across. And believe me, I've been to a lot of countries and worked in a lot of countries, and I've not seen many people who actually have the vision of what Dr. Shetty had. And more importantly, what Dr. Shetty dreamt during the 1990s, he was actually able to deliver today when we stand in 2016. And he thinks the power of a leader is not in the asset or the bank balance. It's the number of talented, passionate people who are willing to follow the leader to build an institution. A person who has the loyalty of the maximum number of these people is the most powerful person. And that's, by definition, is his leader. And Dr. Shetty's model, unlike the Arvind Eye Hospital model, is not actually wholly a family model. People like us who have been associated with Dr. Shetty since the 1990s have stuck around. The attrition rate in Dr. Shetty's institutions is extremely low. People who go to him and work with him actually stick to him nearly for the rest of their career. And that's an excellent quality of a leader. And his vision of Narayana Health, which is his brainchild, is an affordable, quality healthcare for the masses. It is not a subsidized healthcare, it is not an inexpensive healthcare, but it is something which you can afford, and that is very, very important while you are delivering healthcare. So in 1989, Dr. Shetty, after he returned from UK, he joined the BM Birla Heart Research Foundation in Calcutta, and then he moved on. And he understood that a lot of well-equipped hospitals are unaffordable by the underprivileged sections of the society. So in 2000, he promoted the Rabindranath Tagore International Institute of Cardiac Sciences, and in 2001, he moved on to Bangalore, where he actually has the Narayana Health Institute. So Mother Teresa was, now Saint Teresa, was his inspiration. He was her doctor in the last 5 years of her life, and Dr. Shetty says that I truly believe she was not an ordinary human being like us. She had a true gift, being able to bring a smile to people. And she said to Dr. Shetty that hands that serve are more sacred than the lips that pray. And she was truly an inspiration. And what were his observations? He thought that 80% of the healthcare expenses were borne out of pocket, which was actually true and probably still is true, because our insurance model in this country is extremely low compared to, say, anywhere in the Western country or any developed country. He also found that 47% of the rural and 37% of the urban population either borrowed money or sold assets to pay for medical expenses. And mind you, the cardiac care is an extremely expensive proposition. Any heart surgery would cost, even today, close to about 2 lakh rupees at least in any hospitals. That's the basic cost. It could be more. And only 120,000 heart surgeries used to be performed in 1990s, where there was a need for actually double of that. So his beliefs were the quality of healthcare with low cost. That was one of the things. And medical treatment of the highest quality should be available even to those who could not afford it. Therefore, the cost of the surgery had to come down. So whenever we used to talk about these kind of models and have to have meetings together, with the administrations, with the managers. He was actually a manager's or administrator's nightmare, because he used to have a vision and he wanted it to be implemented, and the rest actually were the people in the background who had to work around it to deliver it. So he was kind of a dictatorial thing when it came to his vision about what he wanted to deliver. The people around him, the medical professionals, also understood that if you work with Dr. Shetty, as with the Arvind High Hospital, your volumes would be high, the skill levels would develop, but your take home would be much lower compared to, say, any other hospitals in those days. And what he said was very important, that charity is not scalable, but a sound business model is. So his model was to subsidize patients with a lesser paying capacity, the way Arvind High Hospital did. He had private wards where patients paid, and he used to subsidize patients. And in 2004, the proportion of patients who paid NH full price to those who could not afford to pay was about 60 to 40. Again, the volume game was the key to the whole area without compromising on the quality. He performed, the number of heart procedures performed every day was almost 8 times the average of other Indian hospitals. When we used to start our career, or even the middle of our career, we used to see that heart care or the heart ICUs were always in cubicles where patients were isolated. Dr. Shetty was the first person who actually devised ways of actually opening up the cubicles. It was so that if you had 5 patients, one besides another, just divided by a curtain if required, you had lesser number of personals, nursing personals or the paramedics to actually watch over the patients. So that was the first kind of steps where it broke the myths about subsidizing the heart care. If you spent less on personals, if you spent less on equipments, if you spent less on other areas, and if your volumes are high, obviously the cost would automatically come down. The other thing which was very revolutionary on those days were actually the machines. A cath lab machine where we perform our angioplasties and angiograms would cost anything around 5 crores in those days. 5 crores. The HPs and the Philips and the Siemens used to charge those money. And today, when Dr. Shetty's hospital, Narayana Health, has at least 50 to 60 or 70 to 75 cath lab machines all across India, we don't buy machines anymore. The company, they park the machines and we give them a monthly rent, and the maintenance cost is theirs, and they take money from us. So that's the way we actually operate nowadays. So the purchase of machines, not only in the high sector areas, but also in the labs and different areas, are all on a rental basis. So it's a kind of a cost sharing and a profit sharing we go by. And the other important thing was the using of generic drugs. So today we have Kiran Majumdar who have tied up, and our drugs in the NH groups are mostly generic, and obviously the cost of the drugs are much, much less. This is actually one area in life where things have actually halved in terms of cost from what it used to be in the 90s or 2000. Now coming to the hospital which started it all was Rabindranath Tagore International Institute of Cardiac Sciences in Kolkata, and it started off in the year 2000, and it had the privilege of providing service not only to people of West Bengal but also the neighboring districts in eastern India as well as the northeastern states, apart from countries like Bangladesh, Nepal, Bhutan, Myanmar and so forth. At the moment we have 613 beds, which is one of the highest in the city. We have 14 state-of-the-art OTs with 6 exclusively for cardiac surgeries, 3 cath labs, 1 pacemaker lab, 160 critical care beds, which is about double of what any other hospital has, and 28 bedded emergency department, and the next best number is actually close to about 10. So we are more than double when it comes to emergency department, and we have a good laboratory service. The emergency department being so big is so important in actually getting into the emergency cardiac care, because we are in the heart care business, so any heart attacks or any other acute cardiac problems requires to have a good emergency services. You could have a big hospital with a lot of beds, but if your emergency services are not good, are not big, you will not be able to accommodate them. So, after actually the Rabindranath Tagore International Institute of Cardiac Sciences came to force, we get a lot of district patients to come. Now, this was my personal endeavor along with Dr. Shetty's ideas that we need to also focus on the underprivileged in urban settings. And this was one of the areas which I thought were important. This is the film fraternity where they have the technicians who were very, very low salaried and did not have any kind of insurance or people to look after them. Even the film fraternity, the artists who were in the older generations didn't have any health security with them. So we decided that we were going to issue them privileged health cards. We provided them with insurance. We tied them up with the artist forum where they actually pay a nominal fee for the insurance, and we delivered them privileged health cards. We actually have about 2,500 of these technicians from the film studios who are tied up with us. We have different kind of ventures in the urban areas where the underprivileged are looked after. And this was one of my passions from my childhood, cricket. So CAB, or Cricket Association of Bengal, is actually one of the richest board in the world in terms of the money. But the lowest rung, lowest denominator in this whole association were actually the ground staff, or the malis which we call them. And they are the people without whom the whole infrastructure of the game doesn't advance. But unfortunately, there were no insurances, no health checkups, no camps to look after them. So we decided actually to go into these areas, and recently we went with a free health camp and looked after these people in a very, very comprehensive manner. And we have also issued them with health cards, and we will look after them. So this was actually the whole idea behind how we looked into the healthcare business for the underprivileged sections of the urban media. The next focus was actually on the rural health, and my heading is actually the rural reluctance. So what do you mean by rural reluctance? Rural reluctance is actually by definition where trained doctors, trained medical professionals do not want to go to the rural settings to treat patients. The government of India, government of the different countries have tried their best to put these people like us who have just graduated, going into the rural settings. Unfortunately, because of different reasons, it is not only the pay scale, but because of the infrastructure which you have, because of the lack of facilities which they have, people like the young doctors, they do not want to go to the rural settings. People have tried, the government have tried penalizing them, it didn't work. The reasons we have to understand is, first of all, when you are in the classrooms, when you are graduating, you are actually exposed to the most of the advanced technologies which you have in the country. And suddenly from this area, you are thrown into the rural diaspora, the villages, where you are actually exposed to nothing. You don't have medicines, you have a patient in front of you who has multiple problems, and you have a stethoscope to just diagnose those problems. So it was, I thought, a huge disparity between the training which you received in your classrooms, and suddenly you are exposed to the worst of the scenarios. So I believed always that the most experienced people, the most experienced doctors actually should go to the places in the rural settings where you have scarce availability of facilities. Your experience can actually deal with those problems. The inexperienced, the greenhorns, should be actually gradually developing experiences in the urban settings. So the rural health landscape is actually very scary. Of the 700 million people living in about 6 lakhs villages, 66% do not have any access to critical medicines. 31% of the population travels more than 30 kilometers to seek healthcare in rural India. So we do not know exactly what happens to the people when they have acute problems. Lack of basic investigation tools to diagnose heart problems, lack of awareness of heart-friendly habits and environments. Primary to secondary healthcare has very little focus on heart care, and 80% of the population in rural India is served by 20% medics with little or no infrastructure for basic healthcare. And here is the skew. We have 70 to 80% doctors in the urban area treating 20% of the patients, whereas the majority of the patients or population in the rural India have no doctors to look after. So what were the solutions to healthcare in rural India? These are my suggestions, which I thought that e-health is the only way forward, and it has to be done in a spoke and hub model, which I am going to discuss or elaborate in a little while. The government organizations, the non-government organizations, international agencies need to pull in the resources. You just cannot depend on any particular kind of organization. It has to be a pan across the whole globe. Any help is actually desirable, any help is welcome. And go hard on the awareness drive, keeping the socio-cultural issues in mind. When you travel into villages, when you travel into the rural areas, you will understand that there is a huge socio-cultural divide which divides the urban from the rural population, and that you have to keep in mind while you are dealing with this population. So my mentor, I would say, is Dr. Devi Shetty, who I know him since 1989, and we have shared a lot of dreams together in delivering quality, affordable healthcare for the Indians. And we joined hands in setting up the Rabindranath Tagore International Institute of Cardiac Sciences in 2000. And we share the same inspiration with Saint Teresa. I happened to be meeting her in 1996 or 96, I think, in one of the programs where we were together. And this was a beautiful thing she said, that not all of us can do great things, but we can all do small things with great love. And that is, I think, the key to what I believe and what inspired me to do what I try to do today. So this is actually a village called Moinapur, and it was my trusted destiny. It's in Bankura, which is the district of West Bengal. It is located 50 kilometers towards the east from the district headquarters of Bankura and 200 kilometers from Kolkata by train. The population census said there were about 19,853 people who live in Moinapur. The demographics of the health and the healthcare in Bankura is, the population is about 35 lakhs, medical college you have got 1, district hospital 1, rural hospital 5, primary health center 17, sub-center 508 and blood bank 1. Except the medical college, the rest of the other facilities, medical facilities, is very, very scarce in the district of Bankura. So as we travel into that place, these are the beautiful sceneries when we travel there, and these are some sites of that particular place. It's a very, very old village, about 350 years old. People like Vidyasagar, who are one of the luminaries of the world, actually have traveled there, and the buildings which you see on the top are about 300 years old, still standing. And if you see the bottom corner, this is the jungle areas which people have to travel to sometimes. So the nearest hospital is about 60 kilometers away. The primary health center is about 20 kilometers away. There is no ambulance, there is no registered medical practitioners, and the first camp which I did was in 2014. So when we did the first heart camp in 2014, we had about 250 patients who attended, and I was the first specialist who actually went into that village in their history. So after a couple of camps, we decided to form a registered foundation, and the name was Moinapur Rural Healthcare Foundation. We had all the components added into this name, and it was founded on the 15th of August 2015 by the people of Mainapur. We involved a lot of people of Mainapur, and it facilitates access to tertiary health care with the people of the Mainapur adjoining villages. Now this model is something which I am going to describe. The visions of Mainapur Rural Healthcare Foundation. The healthcare is the fundamental right of every citizen of India, and it's not about charity. This facilitates the delivery of the right to healthcare facilities for individuals of Mainapur and adjoining villages. This is in a very, very nascent stage, and this is more of an idea which we are trying to implement rather than what we have really achieved in the last couple of years. The objectives are reaching to the economically underprivileged rural heart patients, and we need to diagnose the treatable heart problems in the children and adults. And this is where I have to say that diagnosis of a heart problem is so very important before you actually start treating them. If you don't know what you have, you don't know what to treat. You can have all kinds of statistics, all kinds of prevalence incidence reports about how much heart problems are in a particular area, but it's no good unless actually you diagnose them. And what the MRHF does is also to have a rural-urban connect, and the other important thing which we do is follow up the treated patients. So unlike the previous foundation, unlike what Dr. Shetty does, we are not into the business of treating patients surgically. We are more of a facilitator, we are more of a pick-up, diagnosis, and then to see what best can be done for them, and also more importantly to have these patients be followed up, because there is no facilities where actually the patients are seen by any doctor at any point of time in this particular village and the surroundings. The methodology has been again through heart camps, and I have a 24/7 communication lines open with particular couple of peoples there, and we have e-health and we facilitate. The dates of the heart camps are more or less fixed. We do it on public holidays. It's 26th of January, March, 15th of August, and during the Durga Puja. We have two colleagues of you who will be traveling with me on the 12th of October for having the heart camp there. The venue is actually a primary school which was established in 1868, and the headmaster or the principal of that school actually were always kind enough to give the school during these public holidays. So that's the venue of the heart camps. We do ECGs, we do the basic bloods, I do the consultations with my colleagues, and these are non-chargeable. And we have the pamphlets which we distribute for advertisements for the camps, for dates of the camps, and also through the cable TV operators. These are some pictures of the heart camps. On the left-hand side of the screen, we have this heart camp venue in the school, and I do a public awareness talk before the heart camp and sometimes after the heart camps. So people, I try to encourage them to come over, and we just talk about some basic issues, and it's more of an interactive session which we have. So these are the MRHF members. These are members who are originally from the village but are working definitely in some urban places, particularly some people in Calcutta and some in other areas of the country. And this is the meeting which will take place during the camps which we have, and this is the MRHF executive body meeting which is happening. This is a picture of that. The NH team consists of myself and my secretary and the heart camp coordinator and a couple of doctors from time to time. And this is one of the pictures of the camp which is undergoing in a classroom. So after that, we have come to the stage where we have collaboration with another NGO who were interested in the e-health. The e-health, I thought, were one of the important areas besides the heart camps where we can connect with these in a very consistent manner throughout the year. So we have coordinators, one at the Calcutta end, and we have a coordinator at the Moinapur end. We have a rural health practitioner at Moinapur. Now, what is a rural health practitioner?